for everything. I will present a few slides. So no conflict of interest. This is the agenda, some experimental evidence. This is just to remind you that there is a cross-link between the brain injury and acute lung injury, some treatments that we apply to minimize ventilator-induced lung injury are in contrast or opposite to what we would like to have for minimize brain injury. And on the other side, in order to minimize brain injury, as you can see, we apply different treatments that can be associated with more lung injury. So it's a balance between the two. And between the brain injury and the acute lung injury, probably the cross-link is mainly due to the role of inflammatory mediators. Now, this is an experimental study that we did some years ago, in which we analyzed the effects on the lung of higher intracranial pressure up to 40 millimeters of mercury in normal animals, as you can see here, in position, and in animals in which we induced acute lung injury. This is animals in control with higher intracranial pressure, with induction of RDS and RDS plus intracranial hypertension. And as you can see here, this is the extravascular lung water after 4 hours. In the control group, no changes. In the group in which we induce an increase in intracranial pressure, you see that there is a small but significant increase in extravascular lung water, and as you can see also here from the CT scan. Of course, with RDS, we got an increase in extravascular lung water, as you can see here, but even worse when we associated lung injury and brain injury. Just to tell you that when we have an increase in intracranial pressure, the lung suffer, in case much weaker, and even more if there is associated some pulmonary injury. And this is also a very recent study from our group conducted by Rodriguez Gonzalez, which was fellows in our unit for some months, from Jesus Villar group, in which we look at the effects of the conditioned medium from alveolar epithelial cells stimulated with LPS. And then we look at the possible damage of different neuro cells. And as you can see here, when we added the medium derived by the activation of alveolar epithelial cells by LPS, there was a major increase. This is just one of the parameters that we measure in NSA produced by the neural cells. So this means that the mediators released by the lung, by the infected lung, may damage the neural cells. And this is a study on animals in vivo looking at the effect of protective mechanical ventilation in animals with brain damage. And also without brain damage, but I present you just data on brain damage. One group ventilated with a relatively low tidal volume and a higher level of PEEP as compared to a relatively higher tidal volume, so 6 versus 10, and low PEEP, so PEEP was 5 in the group of higher PEEP and 1 centimeter of water in the group of lower PEEP in rats. And as you can see here, this damaged lung, as I showed you before, when you have brain injury, was protected when it was ventilated with more protective ventilation. So these are just experimental studies showing that the lung is damaged after brain injury. There is even more damage when we associate brain injury and lung injury, and protective mechanical ventilation with low tidal volume and moderate level of PEEP may be beneficial to reduce lung injury, at least in experimental animals. And this is also another interesting study. This study is not from our group, but from Luis Blanc group, in which animals were ventilated with a lower or higher tidal volume or spontaneous breathing, and they look at different damages, anatomical damage in the brain. In this case, the central amygdala, but they analyzed other areas. And as you can see here, when animals were ventilated with higher tidal volume as compared to lower tidal volume, there was much more damage in the brain. And of course, if the animal were in spontaneous breathing, this is not suggesting that patients should be maintaining this spontaneous breathing, but at least in this experimental, there was an effect of mechanical ventilation on the brain. So it's a really crosstalk between these. These are clinical data. This is a study now dated a few years ago, but now we have a refresh of this data that will be submitted very soon. These are data looking at the effects of the occurrence of respiratory, cardiovascular, and acute kidney injury in non-neurological large cohort of patients in hemorrhagic stroke, ischemic stroke, and brain trauma. And as you can see here, the most serious complications in these patients are respiratory and cardiovascular. And as you can see here, that even if respiratory complications in neurologic patients are, at least from our studies, are a little bit less compared to a total non-neurologic population, are quite relevant among 30%. So 30% of the patients with brain damage, more or less in a uniform way from hemorrhagic, ischemic, or brain trauma, they can suffer from a lung injury. And we know from previous studies that the number of multiple organ dysfunctions may affect the outcome of the patient, but also the non-favorable neurologic outcome. As you can see here, the patient with higher multiple dysfunction score, they had much more non-favorable neurologic outcome. So we have to cure the overall patient from the brain to the peripheral organs to improve outcome in our patients. What about protective mechanical ventilation? We have two strategies, one brain-directed, one lung-protective. The brain-directed, as you know, is to optimize oxygen delivery, is to control PCO2, eventually with higher tidal volume and minute ventilation, and minimize potential effect of PEEP on the brain. On the other side, if you want a lung protective strategy, we have to avoid overdistension, so to reduce the inspiratory stress, to avoid the recruitment by using recruitment maneuver or PEEP, and limit tidal stress, so minimizing the driving pressure, so the difference between plateau and PEEP. So first of all, what really matters for the brain? To avoid hypoxemia, to protect the cerebral perfusion, on the other side, avoid hypotension, avoiding high intracranial pressure, and avoiding inadvertent hypocapnia. And this is both in edema and in contusion condition. And as we discussed before, we are mainly focused on the CCP, which is the difference between mean arterial pressure and the ICP. We know now from different clinical studies that tidal volume is associated with an increased risk to develop acute lung injury or RDS in neurologic patients. From this study on MASHA, you see that patients ventilated with tidal volume higher than 11 milliliters per kilogram protected body weight were associated with an incidence of RDS of at least 40%, while patients ventilated with much less tidal volume, less than 9, were associated with a much lower rate of RDS. So tidal volume plays a major role to prevent the occurrence of lung injury in these patients. And this is a very nice study on a large population of patients from the United States, and showing that at least here there's patient with spontaneous intracerebral hemorrhage, the prevalence of RDS was high, more or less identical from our study, around 30%. As you can see here, the independent risk factor for development of RDS were tidal volume again. So when tidal volume was higher than 8 milliliters per kilogram predicted body weight, the risk was 1.8. Other factors like fluid balance or the need of packed red blood cell exposure were also associated with the risk of RDS. And again, this emphasizes the role of the importance monitoring of hemodynamics in these patients and fluid balance in these patients. These are our studies just recently published. This is a general population of non-lung injured patients, including patients after cardiac arrest or a brain injury. And as you can see here we look at the effects on the free mechanical ventilation days in patients ventilated with a tidal volume of more than 10 or between 6 and 10 and equal or less than 6. And as you can see here, the number of free mechanical ventilation days was much higher in those patients preventively ventilated with lower tidal volume, including cardiac arrest and neurologic patients. These are patients without RDS. And we published also a subsequent study just recently on CCM, looking at the effects of tidal volume as an independent factor to prevent pulmonary complication, again in non-RDS patients. And you can see here the number of complications were much less when patients ventilated with lower tidal volume, and also survival 0.05, but there's a very important trend towards a reduction even in mortality when patients without lung injury were ventilated with lower tidal volume. So more evidence that lower tidal volume play a major role to improve outcome in non-RDS patients. And these are data from patients after cardiac arrest. This is again just published, I think 1 month ago, from Yuda Futerazan, again from our group. She was working in Bangkok, she was a fellow in our unit, and it's a very large population of cohort of patients. And you can see here from 98 to 2010, there was a major reduction in the tidal volume size in patients after cardiac arrest, with a progressive increase in respiratory rate. This is extremely important, and an increase to moderate level of PEEP. And this was associated, as you can see here, when standardized and corrected for the severity of the patients, to a major reduction in the progression of lung injury. So in after cardiac arrest and brain injury patients, we have more evidence that low tidal volume may be really effective. And there are two large studies ongoing. One is the Dutch study. We are also part of this, comparing non-injured patients, including NEURO patients and patients after cardiac arrest, 4 and 6 versus 8 to 10 milliliters per kilogram predicted body weight. And there is also the EPALI study, which is a Spanish study, which is a very similar design. And we also agreed in advance to combine the data from these two large randomized studies ongoing to get a final response about the role of low tidal volume in non-injured patients. What about recruitment in patients with brain injury? This is an old study, but I think extremely interesting, from Thomas Bain, showing that when we apply recruitment maneuver in our patient in order to optimize oxygenation, we have to be very careful and to monitor patients. As you can see, the jugular bulb saturation decreased markedly during the maneuver. So we can do that, but we have to do that very carefully under careful monitoring. And this is a very interesting study from NEMR in Brazil, looking at the effects of CPAP maneuver versus pressure control maneuver. So you just increase the level of PEEP and you apply some increased level of plateau pressure by pressure control. And as you can see here, pressure control recruitment maneuver was associated with less increase in intracranial pressure and better response in oxygenation and a better maintenance of CPP. So just to tell you that different recruitment maneuver can have different effects on the brain. What about PEEP? Most of the studies now clearly show that if you need PEEP, you can increase PEEP at least up to 15 centimeters of water. Don't worry about that, of course, under careful monitoring. This is a very nice study from Caricato and colleagues, showing that the compliance of the patient may play a role in the effects of PEEP in these patients. In the group A, patients have a higher compliance, in the group compliance was lower, and as you can see here, the CPP and the flow Doppler, the MCA, were less affected when the compliance was lower, while were much more effective when the compliance was higher. So when we apply PEEP and the patient do not need PEEP, of course, this kind of more negative effects on the intracranial pressure. But if you apply PEEP in the condition which we really need PEEP, the effects on the brain are much less. And this is also shown by this study by Luciana Mascia, that as you can see here, when you have an increase in the elastance of the respiratory system, so a decrease in the compliance, this is associated with an increase in the intracranial pressure, while a decrease in the elastance, so an improvement in compliance, is associated with a decrease in intracranial pressure with PEEP. So when you improve the compliance, so the PEEP is really beneficial, the application of PEEP is associated with a decrease in intracranial pressure and not one increase. So this means that the clinical condition of the patients play a major role to determine the effects of PEEP on the brain. And this is a very recent study, again from NEMR, looking at the brain tissue oxygenation and PEEP and intracranial pressure. Just to show you, they changed PEEP from 5 to 15 in RDS patients with severe traumatic brain injury. The intracranial pressure did not change too much within this range of PEEP because the patient probably needed PEEP. And interestingly, you can see here the intracranial oxygenation increases. So the application of PEEP not only was beneficial on the lung, but also on the brain, increasing oxygenation in the brain. So you can accept higher level of PEEP when the patient is really required to need them. And also the position. This is a very old study that I found, however, very interesting, showing that if you apply PEEP and the patient is in reverse ventricular position, so head up, the effects of PEEP are much less. So the effects of intrathoracic pressure are much less when you are in head-up position as compared to supine position. So if you combine all these kind of things, you see that PEEP is not such a devil as we believed before in this kind of patients. What about very particular maneuver in these patients? Very few data on prone position. Of course, this is a very extreme condition. This is one of the only study, as far as I know, in which they measure the intracranial pressure and associated with prone position, and they found an improvement in oxygenation with prone position in this group of patients with subarachnoid hemorrhage and severe RDS. Intracranial pressure increased. So this means that when you perform the maneuver, you have to carefully monitor intracranial pressure, of course. And interestingly, again, the oxygenation in the brain increased. So you can use this maneuver, but under selected, in selected patient and under carefully cerebral monitoring, and for probably a period enough, not too long. What about hypocapnia? We know now that we should maintain hypocapnia in our patients. Hypocapnia, however, should not be banned. This could be for discussion afterwards. For example, if you have an ICP emergency, this, in my opinion, should be always taken into account. And for example, we have to be very careful to manage the PCO2, especially higher PCO2, if we have in presence of low intracranial compliance. And these are some of the conditions that I mentioned. So I think that we have to avoid hypocapnia. We should maintain physiology, but in some condition, we have also to consider hypocapnia or moderate hypocapnia. There are other systems. For example, this is again from Thomas Bain. He worked a lot on that, on complex extrapolar lung assist in patients with RDS and severe brain injury, but we have very few data. For example, just I report this study. You see in this study, they found a decrease in the PCO2. Okay, we say, wow, this is nice. They found an increase in PO2. This is nice. But you see in one patient, there was a decrease in ICP. In another patient, there was an increase in ICP. So regarding the ECMO or this kind of system in these patients, also not using anticoagulation, we have to be very careful. I think we have to be very cautious to use this system in these patients. There are few randomized trials looking at the protective ventilation and effect on outcome. This is one of the few trials with very few patients. They enrolled also patients with brain injury and cardiac arrest. They compared to PEEP 2 and 5 with 8 milliliters per kilogram, and they found a reduction in the VAP in the group treated with prophylactic PEEP and a reduction in the hypoxemia phenomena. But we are planning a very large study on effect of PEEP in non-injured lung injury patients. So, but we have some data suggesting that PEEP can be good. And this is another study, is really in donors from Luciana Mascia, again comparing higher tidal volume and lower PEEP, compared with low tidal volume and higher PEEP. And as you can see here, those patients treated with some protective mechanical ventilation, low tidal volume, and moderate PEEP level, these were, in my opinion, too much, 8 to 10, were associated with better lung donor eligibility and lung harvested. And this is a study in Italy with many difficulties, is progressing, in which comparing low tidal volume and higher PEEP as compared to higher tidal volume and lower PEEP in brain injury patients. Few comments about respiratory monitoring. This is a review we published a few years ago, just suggesting you and that what we do personally, that in more severe patients, of course, we have ICP monitoring. We use more and more transcranial Doppler, that I think is extremely important in these patients, but it's open for discussion. We use much less and less, at least in our experience, SGI-VO2, and we don't use routinely the brain tissue oxygenation. We believe, as we discussed before, that it's very important to have invasive arterial pressure monitoring, and we are using more and more in more severe patients system like a calibrated system in these patients. Just a few last slides, one related to weaning that I think is very important, related to the respiratory management of these patients. I think it's very important to have guidelines in your unit. And I suggest this very nice study from a Samir Shaber group, in which he suggests protective ventilation, as you can see here, PEEP around 3 to 5, protected tidal volume, respiratory rate to maintain normocapnia or moderate hypocapnia, and to use antibiotics, of course, to prevent infection, and to early perform spontaneous breathing, but only when inspiratory support is less than 10 or spontaneous breathing and FiO2 are less than 40% for 30 minutes, and Glasgow Coma Scale is more than 10, and cough is spontaneously present. So to use these guidelines, you can improve or facilitate weaning of these patients, and we did in our unit. I think this is very important for all of you, to have strict guidelines in your unit to organize weaning. And what about tracheo? It's a long story, but I want to show you this very provocative study, which was published, and I think it's interesting because showing that early tracheostomy, even in brain injury, can be associated with decreased VAP, but with increased mortality. This is a long story. If you want, we can discuss this, but this is interesting. We have also new data which are in line with this. So I think that also tracheo should be done, of course, in this patient when needed, but just my word is a word of caution to use tracheo in widespread in these patients. What about physiotherapy? Just 2 slides. No clear data in more severe patients. Probably it's better to be very quiet, just very simple passive physiotherapy, and eventually physiotherapy in the more in the weaning phase, in the rehabilitation phase. But in acute phase, we have no clear data that suggests that this can be helpful. We have finished the time. Yes, so these were just some data in neuro, but eventually this is what we found, that you see the tidal volume in neuro patients is a little bit higher than we are commonly used. So again, a suggestion to reduce the tidal volume, and PEEP around 5 seems to be a good level to prevent RDS, and higher if you have RDS. Conclusion, this is a sort of bundle of treatment, and that you can see here in the normal lung, on RDS lung, what you should do, but just to remember that there are also not only tidal volume and PEEP and respiratory rate, but also remove the excess dead space, so the filter in many cases, if you have a problem with CO2, ensure patient ventilator synchrony, we don't look very often at this point, sedation, check the endotracheal obstruction, and the drainage of this can be important. This is just a sort of bundle that I think is important to have in mind, then you can agree or not, but to have at least some rules in your unit to improve your treatment. Thank you very much.
One quick question. Just a question on the relative proportion of ARDS, or define as you want. You have shown papers talking about 27% ARDS after spontaneous intracerebral hemorrhage, or prone position because of ARDS in subarachnoid hemorrhage. Very often, I think I live in a different world, and I think that you also have this impression. It depends on definition, and also it depends how bad you are, because I can't really believe that ARDS is a problem in subarachnoid hemorrhage. What do you think?
Yes, I mean, in fact, the difference, there are different rates of RDS, or at least the severity of RDS in these patients. For example, in our study, we found much lower rates of severe RDS, very low, and if combined, a very poor outcome. But mild to moderate, you can reach 25 to 30% if you measure. The problem is if this mild respiratory insufficiency can play a role or not on outcome. And this is something that we have to understand more. What we know now is that we can influence this. So now we have more and more data we will see from randomized trials that, however, our non-optimal protective mechanical ventilation, non-optimal fluid management can worsen the patient. So I agree with you. It's possible that this difference can be due to the pathology by itself, even if from our study, yes, was a little bit less in brain trauma compared to subarachnoid or stroke, but 10-15%. But I think it makes a major difference, the overall treatment of the patients, which is extremely important. That's my message today. I suggest to have some guidelines in your unit, even if you talk each other. It depends on your organization, but better to have clear ideas on how to manage these patients, even in addition to the brain by itself.
Thank you.
Okay, thank you, Paolo.